Thank you, sir, for giving me the opportunity to be a part of this discussion. Hi, this is Dr. Pavni, Senior Registrar from D.Y. Patil Hospital, Navi Mumbai. This is a case study by Dr. Stefanos Diapoulos. So we have a case. This case concerns a 58-year-old woman, which presents with a complaint of mass in the left breast. On a physical examination, there was a 4 centimeter mass on the left breast, and there was no nipple discharge or any retraction. She was further followed up by mammography, ultrasound guided core biopsy of the lesion, histopathological report, and immunohistochemistry. These are the mammography findings. We see a high density mass in the upper outer quadrant of the left breast. Taking a closer look, the mass is well circumscribed, round to oval high density mass, smooth lobulation. The findings were confirmed on ultrasound, and they were consistent with the mammography finding. On Doppler, there was no significant internal vascularity. Now, at first glance, this may seem similar to a benign breast lesion like fibroadenoma. Further, the patient was advised for ultrasound-guided core biopsy, and on histopathological report, it turns out to be a Ki67 proliferation index of 50%, estrogen receptor negative for the disease. There was a 20% progesterone receptor positive cell, and it was negative for HER2/neu. On immunohistochemistry, the neoplastic cells were positive for CK-pan and synaptophysin, while it was negative for LCA. As per literature, the above histological and immunohistochemical findings were compatible with high-grade small cell neuroendocrine carcinoma, which is very rare. And let me dive deep into the case, this case, which indicates that it's a very aggressive type of neuroendocrine differentiation cancer. There are only few cases in literature that accounts for less than 1% of all breast cancer. Extrapulmonary location of the small cell cancer is rare in breast and accounts for 5% of small cell extrapulmonary cancers. The WHO classification categorizes small cell neuroendocrine carcinoma. Talking about prognosis is usually worse when compared with invasive breast cancers. The diagnosis of the neuroendocrine breast cancer requires the presence of neuroendocrine features in at least 50% of malignant cells, the exclusion of non-mammary primary tumor, as well as presence of an in situ component in the breast histology. The treatment and prognosis of this cancer are still not well established, and yes, it has a very poor prognosis and warrants treatment with platinum-based chemotherapy. Thank you.
Thank you very much. This is a very odd case and neuroendocrine tumor in the breast. So I want the expert to discuss a little bit, highlight for the fellows what can happen and what is the management in this case. And I saw, it was looking like a fibroadenoma. So we have to be little careful when we see fibroadenomas, we talk fibroadenomas, whether biopsy is a must or not. All these things, I leave it to the best imaging experts. Yeah. Anybody from Sabita can highlight, Palak, all you, anybody here? Nikita? Bijal? Anything, that's very rare, you have to be careful, that's why I showed.
Sir, but considering that all the margins are not well circumscribed, there are some macro lobulations, some micro also. Just go back to that ultrasound picture. And in fact, it is not a clean oval mass.
Right.
It is heterogeneous in echogenicity. I would definitely not give it up as a fibroadenoma. And in fact, in my next talk also, I'm talking about when you can leave lesions alone, and when you really need to biopsy it. About neuroendocrine tumors, in fact, I really don't have much experience.
Yeah.
But I would definitely say this deserves a biopsy.
Yeah, let me give in the surgical input also. So the minute I see a lesion in the retromammary space, I'm not looking at fibroadenomas. So correct me, all the imaging people here. So there is something that is not okay here. Yes, what Bijal picked up was perfect, that it is, with microlobulations and all this. I would not have thought about a fibroadenoma at all. That means it does warrant a biopsy. I would have looked at maybe a triple negative breast cancer, which also presents the same way. That would be my first clinical diagnosis on her. I don't know what the clinical impression was on palpation. It could have been easily palpated as well. So this would warrant a biopsy. Neuroendocrine is not our clinical impression ever. It's a pathological diagnosis. That means only after a biopsy can you ever say it's a neuroendocrine. Otherwise, on imaging, I think neuroendocrine doesn't have any characteristic feature. It is usually confused with the triple negative only, and it behaves like that when you look at it. So I think that's what my impression is.
Thank you.
I'm sure more people will come in. So for the next session, which is on basics to advances in multiparametric ultrasonography, I'll request Dr. Kakoli Borthakur to moderate this session. She's a consultant fetal medicine at Kokilaben Dhirubhai Ambani Hospital with numerous papers and presentation in various national and international conferences.
Good morning, everyone. It's indeed a proud privilege to be part of all of you in this esteemed conference. Ultrasound has always served as a good diagnostic modality, as a good adjunct to solving problem-solving scenarios and in diagnostic imaging of the breast. And if we're coming to the newer technologies of ultrasound with the different probe technologies, the advancements, the elastography, and certain all other things combined together. And more importantly, in a developing country like us, where we are always short of resources, ultrasound serves as a good adjunct considering the availability and the resources here. Now, in this panel, we'll be having a sort of a long, quite a few lectures, which are wonderfully curated based on the newer advances. We have decorated list of chairpersons here. To start with, I have Dr. Bhavna Sunavane, who is the professor and head Department of Radiodiagnostic, IGGMC Nagpur, with special interest in breast imaging and an ex-dean of IGCMC Nagpur. I welcome you, Dr. Bhavna. Then we have Dr. Mona Mehta. Are you there, ma'am? We have Dr. Mona Mehta, who is a senior consultant in HOD Department of X-ray, Ultrasound and Mammography. She has special, she is in the Institute of Leelavati Hospital. She is working there. And she has a postgraduate training in diagnostic imaging from KEM Mumbai. And areas of interest is ultrasound and breast imaging, mammography guided interventions, and a DNB teacher for more than 10 years now. Now we have the next chairperson, who is Dr. Netaji R. Patil, who is the consultant radiologist at BKL Valavalkar Rural Medical College, Durban, and he is a college coordinator for that Rural Medical College Valavalkar, and he has got special areas of clinical expertise in oncoradiology, interventional radiology, spinal interventions, and also an expertise in CT, MRI, ultrasound, and conventional X-ray reporting. We have our next chairperson, who is Dr. Uday Bhan Singh, who is the director and consultant of Noble Star Diagnostic and Intervention Center. He is trained in the All India Institute of Medical Sciences, New Delhi, and Apollo Hospital, New Delhi. He's worked in Jaslok and Bridge Candy Hospital. He has got a series of national and international papers to his credit, and is a speaker in specialty and other specialities in state, national, and international conferences. Then we have none other than our dearest Dr. Deepak Patkar, who is the Director of Medical Services, Head and Department of Imaging, Nanavati MEX Super Speciality Hospital. Sir is the past president of IRI 2020, Chairman Scientific Committee AOCR 2018. He's got nearly 35 years of experience in the field of radiology, and he's got a long biodata, which I can't be reading it through the whole day. I would be reading it out. And advisory member, board member, WHO classification of brain tumor, received the Best Radiology Teacher Award in 2019. And I don't want to spend the rest of the day speaking about Dr. Patkar because it's just about endless. Okay. Now I request all the chairpersons to take over and take us through this wonderful session. Thank you.
Thank you. Now we will be starting with role of ultrasonography in breast imaging and using Byrad's lexicon. Bijal Zankaria, please. Bijal Zankaria.
Of these very enlightened chairpersons and the moderator. Thank you, Britt, and thank you, Palak, for having us over. This is going to be, first of all, a little bit of a basic session on breast ultrasound. It's difficult to fit BIRADS in like 12 to 13 minutes. I'm just going to go over the highlights and then let the others read up for whatever is next. So the traditional use of breast ultrasound has always been to differentiate cystic from solid masses. Till Dr. Stavros, 3 decades back, in a very lovely paper said that we could differentiate benign from malignant solid masses. And if I have to just show one slide in the whole talk, and if you want Purvi, I can go away after I finish this slide and look at all the mammograms and just see how similar each one of them looks. It is the ultrasound which helps us to characterize the lesion further. And therefore, let's look at each one of these and see what they showed us. Benign. Cancer, very well seen on ultrasound. Papilloma, it could have been benign, could have been malignant, but look at the characterization on ultrasound. Very typically benign, very malignant, and a dermal lesion. And all this characterization has happened only because of ultrasound. So today, ultrasound is an extremely powerful tool in our hands, not only for screening of dense breasts, but as a primary modality to do any kind of intervention, so much so that the American College of Radiology has devoted an entire section to breast ultrasound. So let's go on to BIRADS, which is the Breast Imaging Reporting and Data System. The whole idea is to issue meaningful and unambiguous reports with a uniform lexicon, which is followed all over the world, so that we can explain in typical terms as to the abnormalities seen, and then give our interpretation of these abnormalities with the help of assessment categories and talk to people about our degree of suspicion and whether a biopsy is indicated or not. It's been 11 years since the last BIRADS, and it should be coming out anytime now. And in the talk, I'm also going to highlight a couple of things of the upcoming 6th edition of BIRADS. So if you look at the cheat sheet, there are many things as far as the lexicon is concerned. And it's impossible to go through everything. Just go on to acr.org and you'll read up all of it. And we'll be talking a little bit about the assessment categories. Now, when we look at a mass on ultrasound, we are going to be talking about its shape, which could be oval. It could also have gentle bi or trilobulations, and then it is still called oval. The word lobulated is probably going to come back in the 6th edition. I really missed that though. Round and irregular. So all the masses of the world go into one of these 3 shapes on BIRADS. An important thing about ultrasound is, and this is when Tanvi explained all the layers of the breast. We have alternate hyper, hypo, hyper, hypo, hyper when the patient is in a supine position. Benign lesions respect these layers. So when the longest axis of the lesion is parallel to the skin, its orientation is considered as being wider and tall or parallel, and it is very likely to be benign. Cancers have no such respect for boundaries, and therefore they are usually not parallel. Margins, if 100% of them are seen, by margins we mean the border of the mass, where the mass ends and normal tissue begins. If it is circumscribed, it's very likely to be benign, but if it is not so, then it could be indistinct, where there's a wide zone of transition between the lesion and the surrounding structures. Sometimes you get these sharp corners forming acute angles, and therefore they are called as angulated margins. Microlobulated is all these several undulations, and these are speculations, and all of these are suspicious for cancer. Echo pattern, not very reliable. However, if it is cystic or if it is hyperechoic, it is more likely to be benign. We use the term complex cystic and solid for cystic masses with solid nodules, or even solid masses with cystic areas within. But let me come to something that is going to be introduced in the new BIRADS, the term called echogenic rind. And that means this kind of irregular echogenic tissue surrounding a mass, and which disrupts the normal architecture. And this, in fact, has a high positive predictive value for malignancy. It is also said that the measurements with the echogenic rind has the best correlation with histology. So once the 6th edition comes out, probably it will change the way we take our measurements. Another thing that has come out is non-mass. Now, for years we were always confused as to what to call this, something like this, vague, hypoechoic, no shape, no margins, no 3D orientation. What do we call it? The 6th edition has come out with this term of non-mass, which does not conform to a criteria of a mass, may be seen in 2 planes, but predominantly in 1 plane, as we are seeing here. It is really vague, but now we have a word for it, non-mass. This lady had come for screening, and Madhvi would jump at the tomo and say, obviously this is like such an obvious area of architectural distortion. However, this is what non-mass looks like on ultrasound, and this was just a radial scar when we biopsied it. Another area of non-mass, small, hypoechoic, vague areas, no margins, no shape, few calcific foci within. She had a bloody nipple discharge. We can see segmental microcalcifications on the mammogram, and this turned out to be DCIS. So this kind of non-mass can also act on ultrasound for us to confidently do a biopsy from these areas. We don't have to resort to stereotactic biopsies only. It's more likely to be malignant if it is palpable or associated with other clinical findings like a nipple discharge. Vascularity rim is usually benign, but if we have internal and especially penetrating vascularity, it is more likely to be malignant. It is the presence of vascularity which is more important than its absence, and it also guides us for biopsy. Another important thing in ultrasound is elastography, and we have the world-renowned Dr. Bar, who is going to continue after my talk, and I'm going to completely skip it. Special cases, a simple cyst, everybody knows about it. Complicated cysts are cysts with echoes, thin septae, even mobile debris within it. Another term uses clustered microcysts, and these are tiny, tiny cysts which are clumped together and therefore may have a microlobulated appearance with thin septae but no solid nodules. That's the term used, clustered microcysts. I'm really not going through everything. Dr. Tanvi very nicely explained the expansion on lymph nodes. So we get intramammary, internal mammary, supraclavicular. But the axillary is defined by the pectoralis minor muscle, which is so well seen below the major muscle in the upper part of the breast. And whatever is lateral is level 1, retro is level 2, and medial to the pectoralis minor is level 3 axillary lymph nodes. So now that we've said this, let's go on to the assessment categories. And with the help of these categories, we know what to do next with the patient. So 0 is used if we want to do something extra or we want to compare with the priors. And this lady, we were not sure. She had a mass in the breast, but whether these were calcifications, we said we really need to do a mammo. It looked relatively benign. Gave it a 0, did a mammo, and it is an obvious hematoma in the breast, so then we change it to BI-RADS category 2. 1 means everything is nice, and if it is done in a screening situation, we have not found any abnormality, then we document 1 image in each quadrant as well as 1 in the retroareolar area. 2 means we are 100% sure that it is benign, but there are some findings in the breast, unlike 1. What fits into it is a typical cyst. No solid masses, no vascularity within, BI-RADS 2. If there are multiple simple and complicated cysts, more than 3, at least 1 in each breast, then we can also give it as a BI-RADS category 2. Calcified or involuting fibroadenomas, 100% surety of it being benign, BI-RADS category 2. Axillary lump, this is very clearly a lipoma in the breast, BI-RADS category 2. Most fat-containing lesions are going to be BI-RADS 2. Then we go on to BI-RADS 3. And this does not mean it is queri-benign, queri-malignant. It is very likely benign. That means less than 2% chance of malignancy. And as far as ultrasound is concerned, there are only 2 findings with a robust evidence. And one of them is this, and every word here is important. Circumscribed, solid, oval mass in a parallel orientation. Look at this, every word throughout is important to call this a BI-RADS category 3 lesion. It is very likely to be a fibroadenoma, but we need to look at it at 6 months, 12 months, and 24 months, do a short-term follow-up. We have to beware of triple-negative breast cancer in such patients, because if it is something that looks even vaguely like this, and Dr. Tauri showed us a very similar patient, or if it has some pushing margins, it is oval, but look at the margins, they are not circumscribed. We have to keep our antennae up if it does not look like this, because we cannot then call it a BI-RADS 3, we need to call it a BI-RADS 4, and definitely biopsy. Both those on the right turned out to be triple-negative cancers. The second time we call something BI-RADS 3 is an isolated complicated cyst like this, where the malignancy rate is not 0 but less than 1%, so therefore BI-RADS 3. Once again, if multiple bilateral, then BI-RADS 2. After 2 to 3 years of stability, we can push it into BI-RADS 2, but if it changes or the longest diameter increases by 20%, then it would be BI-RADS 4 and we need to biopsy it. Now 4 is a long probability. We need to biopsy these lesions. It is further divided into A, B, and C. A is 2 to 10%. And look at this, little angulated margins in a younger patient who had a sister with breast cancer. We're not going to leave it alone. It's not a BI-RADS 3 lesion. 4A, it turned out to be a fibroadenoma. Another lady practically came for screening, but we saw these few angulated margins, heterogeneous appearance. 4A turned out to be a low-grade mucinous carcinoma. Just going to go on for another 2 minutes. I think it came on for like in 10 minutes. Where's Purvi? Yeah. Okay. And another lesion, which is again not typical BI-RADS 3, it is complex, cystic, and solid. And BI-RADS 4A, this was a complex fibroadenoma. 4B is a little more chance of cancer if we see an intracystic solid mass with vascularity. We don't know it's a papilloma or a papillary carcinoma. 4B, this was a benign papilloma. What looks like Phyllodes tumor, rapidly increasing in size, especially if it has cystic areas within it, would be a 4B, 10 to 50% chance of cancer. And 4C is like this, an irregular solid mass in the breast, very typical cancer. We would call it a 4C. This lady came with a vague thickening in the breast, and on ultrasound, we're just seeing these bands of posterior shadowing, or what is called as the Golden Gate sign, or the picket fence appearance, which is very typical of an invasive lobular cancer, BI-RADS 4C. Category 5 is an irregular mass with microcalcifications within it. We are practically sure, more than 95% sure that it is cancer. And category 6 is known cancer, especially if there's nothing else in the breast which looks suspicious, and it is already proven cancer, BI-RADS 6. In the 5th edition, the management recommendations are separated from assessment categories. So 1 and 2 is routine follow-up, 3 is short-term follow-up, 4 and 5 are biopsy. But in this case, it's a clean cyst. It is 2, but we are still asking her to aspirate it, the cyst, for alleviation of the patient's symptoms. We also need to compare with other modalities and give a single combined assessment. So here there's a BI-RADS 2 lesion in the right breast, another BI-RADS 3 lesion in the right breast, but a 4C lesion in the left breast. So our final BI-RADS would be a 4C, the worst one. We are extremely pessimistic radiologists, and we just look for the worst features on ultrasound for everything. With that, I thank you for your attention.
He is Professor of Radiology at the Northeastern Ohio Medical University. He is also Editor-in-Chief of Journal of Ultrasound in Medicine. Today, sir, will be talking of sonography, the third dimension to multiparametric ultrasonography for breast pathologies. Can it be confidently de-escalate BI-RADS 4A lesions? Welcome.
Thank you, and thank the committee for inviting me to come and talk to you. Before I start this, let me just give you a couple other things. Ultrasound is very, very powerful, and the machines have gotten much better, but you have to use all the tools that are on that machine, because if we see subtle changes on lesions, it really changes our BI-RADS score. So you have to be able to just push the buttons. We have focus zone, we've got frequency, we've got moving the patient. There's always this complaint about refractive shadowing, but usually you can make it go away if you roll the patient in a direction or if you move the transducer. So there's a lot of tricks on B mode and color Doppler to really improve our images on B mode, because really B mode is going to help us really make the diagnosis of the BI-RADS score. And although I love elastography, B mode is really, really important. If we look at the case that they showed just before the T, if you would have looked at that lesion, you would have noticed that there was a mild echogenic halo. That can't be a fibroadenoma. If you looked at the elastography, the lesion was actually softer than fat, which is not possible because it's an artifact. So again, ultrasound has very, very many things that require a lot of education. So it's not the simple thing that you think that you just plop the probe down and you get an answer. You need to do all these things. And if you look at our literature that we've published, before we started doing elastography 20 some years ago, my positive biopsy rate was 20%. Now if you look at our recent things, it's 80%. So we have completely eliminated doing an enormous number of biopsies, and actually it would even be higher, but I get sent cases that they want biopsies that I know are benign, and I get stuck having to biopsy them. So I'm just going to go over a couple quick things about elastography that you have to remember. Remember precompression. Simple cyst here on the left. If we apply pressure, and I can tell I'm applying pressure because look at this rib. It's getting closer and closer to the transducer, so I'm squishing the breast. So I can turn this simple cyst into a beautiful cancer. So you have to make sure that you're not applying pressure. And again, we're using shear wave. We apply this RF pulse. Creates a big boom, and then that creates the shear waves. It's important to realize that RF pulse only generates the shear waves. It's B mode that tracks the shear waves and calculates the shear wave speed. So if you have an artifactal B mode image, you're going to get an inaccurate shear wave. So again, important thing to remember. And again, this is what the supersonics machine does. It's a little bit different in that because it's so fast, it's applying all these different pulses at the same line, and we can get a shear wave. Most of the other vendors will have one pulse that'll go through, and they take time. So in this system, it's very, very fast. Also, when we look at the literature, research has shown that we get the same answer when we look at blinded reads. It's really helpful. And I think the one thing that continues to evolve, and hopefully in the next few years will solve almost all of the problems, is the evaluation of a quality factor. We can look at the shear waves, we can see how tall they are they good shear waves, and give a number and say, okay, on a scale of 1 to 100, this shear wave is 90%, so we're confident. It may come back and say it's 10%, and we know, don't believe that shear wave. And for breast, every time we have a poor quality, it's either a benign cyst or it's a cancer. So again, these tools that are being developed should be out on all the machines in the near future. And again, our biggest problem is what people have called blue cancers or soft cancers, and they in fact are the hardest cancers. And it's because it's like a soundproof wall. The sound doesn't go through them. The shear waves just bounce off of them because they're so stiff. And that way, they just show up as being soft. And again, we've looked at this and published a lot on this. If we look at every vendor, the same cancer is a blue cancer on every vendor's machine. It's not a vendor problem, it's a histology problem. And again, we do sometimes strain, and all of these cases show up as being positive on strain. So again, that's another way of helping and determine if you got good shear wave data. And again, this is what we published. This is the cancer. We often see, which kind of corresponds to that echogenic rind that was talked about in the last talk, because this is not that hard. This cancer has now been really stiff from collagen, but the active cancer is around here, okay? And that's why now we're going to try to include that echogenic rim when we do this. But if we look at this, this is what happens in the back of the machine. Each one of these is a B mode. You'll notice there's a little bit of noise in this, but I can tell you where the time is to the peak and how far it was from the RF pulse. So I can calculate a shear wave speed, but in the cancer, all we get is noise. So again, we can use this as a quality factor. If we see this, we say quality is 0, don't believe your numbers. And again, if we apply compression, this is obviously a cancer, you'll notice that we can again get that rim, and if we push too hard, we can make it. So again, using the pre-compression, if you just apply a little bit and you see a rim, it's probably going to be a cancer. That's another kind of trick. And like I mentioned in that other case, and I'll show you some of the examples, if the lesion is softer than fat, that's not possible. And you know that that's an artifact, and this is one of these very stiff cancers. And again, the BE1 study was a large study using the supersonics machine, and we rely on it for a lot of the information. And what they decided based on almost 1,000 cases was we can upgrade BI-RADS 3s if it's above 50 kilopascals, and we can downgrade 4As if it's less than 30 kilopascals. And that increased the sensitivity and the specificity by using those. Now recently, Dr. Galata from Germany did a nice meta-analysis of all the literature on shear wave imaging, and what he found was basically 3.5 millimeters per second, which I think corresponds to 40 kilopascals, was the best cutoff value to decide if something was benign or malignant. And again, when we look at the literature, that value varies a lot, and it depends, and most of this is probably because people didn't control the amount of pre-compression. So you have to control the pre-compression. And in the last talk I gave yesterday, like I said, what we do in our lab, if you don't apply compression, the Cooper's ligaments are like this. So you get refractive shadowing. So you may not realize it, but when you're doing B mode, you're pushing down to get rid of that refractive shadowing. So you're applying some pre-compression, and you should do that for your B mode imaging. But then when you go to do elastography, you want to release that pressure. Okay, and what we do is, again, we look at the rib, a Cooper's ligament, a calcification, and I just lift up the transducer and you see it fall. It will eventually get as far as you can, but still get a good B mode image, and that's where we do our elastography. And all my sonographers are well trained and do this all the time. In fact, the sonographers are great. They come to me and said, well, this lady has already got a cancer. I've already called the nurse. They're getting ready to do the biopsy. So it's very easy to interpret these, and like I said, all my sonographers are really good at this. Now, there's always false positives and false negatives. So again, need to be aware of these. The false negatives that we have seen have been lymphomas. So lymphoma in the breast is a soft lesion. It's usually, in our experience, it's well circumscribed, very hypoechoic, extremely vascular. So if I see that pattern, I don't believe my elastography will biopsy it, particularly if the patient does have lymphoma, although I'll say we have several patients that we made the diagnosis of lymphoma by doing biopsying that. And our false positives are very common. Fat necrosis, mastitis. Why? They have inflammation. So if you're doing liver elastography, you know if we have inflammation, we get things stiffer, right? When you have an infection, a pimple or whatever, it hurts because there's increased pressure, and that increased pressure increases the stiffness. So again, if we think we have these, we may not do a biopsy, we may do a short-term interval follow-up. And again, for fat necrosis, if we see the calcifications, classic. For fat necrosis on mammo, we feel more confident. A few fibroadenomas, usually in younger women, and we think it may have something to do with hormonal levels. And unfortunately, radial scars or sclerosing lesions are another one that we're picking up more and more, that they show up as being stiff. So a nice example, this is a patient that came in by RADS 3, right? Obviously, they didn't do elastography, so she comes for a 6-month follow-up, and then I yell, why in the hell didn't you do elastography? Turns out to be an invasive ductal cancer. So here we should have upgraded this BI-RADS 3 to a 4 and did a biopsy when she came in the first time. As opposed to this where we have, I would have called this a 4A, it's a little bit lobular, and again, it's very soft. The color is about the same as the background tissue, and again, this was not palpable, and again, we just followed this, and it turned out to be a benign lesion. I don't know what it is, probably a fibroadenoma because we didn't biopsy it. Similar case, again, there's some internal blood flow, and we look at the elastography, and again, the numbers are less than 20, so less than the 30 proposed by both of the things I gave you. And again, we consider this benign, and we would, I would have maybe called this a 4A because there's just a little bit of irregularity, so I would have followed this in 6 months. I wouldn't have called this a 3 and just forgot about it for a year. And actually, this is, turns out that this actually correlating with mammo just turned out to be a fatty benign lesion. Another case, this patient had trauma, and again, it's a little bit stiffer than the background tissue, but its value is 47. So it's a little bit above where we would consider it, but because of trauma, this is a hematoma. So hematomas could be, particularly when they're acute, because again, you have some increased pressure, if you will, they're going to be a little stiff. So we know from the history, and in this case, because we've had several that we thought were hematomas that turned out to be cancers, there's no blood flow. So obviously, if I would have saw blood flow, again, this is multi-parametric ultrasound. We got to put all the pieces together. If there was blood flow in it, it's not a hematoma. Even if it's relatively soft, it's going to be a cancer. Again, this is a patient with lymphoma, but when we look at this, it's an irregular lesion. It has increased blood flow, but it's really stiff. And I told you in our experience, lymphomas are always soft. So I'm going to biopsy this because it's 150 kilopascals, right? Lymphoma should be soft. This is stiff, so it's going to be a cancer, and this was an invasive ductal cancer. And I'm just going to run through a couple more since I'm getting beep. Again, I would call this a 4A. It's palpable mass, and again, very soft, even though it has blood flow. And again, this is, we follow this. It hasn't changed. So again, we think it was probably a fibroadenoma, almost an identical case. We downgrade it to 3. And again, obviously, we see suspicious features, then we are going to always do a biopsy, even if the elastography is negative. And again, this is a surgical scar, and it's soft, and I think I have one, I didn't include it in here. In general, surgical stars is not as stiff as you think, but if you look at the scar with elastography, and there's one area that's much stiffer than the rest of the scar, that's probably going to be a recurrence. And again, turn on color, and if it's really has blood flow in it, be very cautious, because that's probably going to be a malignancy. And since I'm running out of time, again, we use this a lot. And again, another case, this turned out to be PASH on elastography. So many of these lesions that I call 4A turn out to be benign. If we see a lot of color, and I use this a lot for triple negative cancers, they're very stiff. So the last speaker told you that you can get fooled, but those triple negative cancers will be very stiff. So that's another way of using multi-parametric ultrasound to make that diagnosis. So to conclude, new advances in ultrasound, not only elastography, but increased beam mode, increased color. And again, you have to, technique is really critical. Looking for subtle findings, making sure you look at the whole lesion. Doing 3D, we showed you 3D, very helpful to look at the whole lesion, because if one area has a spiculation and the rest is well circumscribed, and you miss the spiculation, you are going to make a wrong diagnosis. And again, based on the BE1 study, the recommendations is upgrade by RADS 3 if it's greater than 50, downgrade 4As if it's less than 30. And like I said, we stopped doing lots of biopsies because elastography is negative, but you have to have put the whole thing together. If it's a 4B lesion and it's soft, we're going to biopsy it because we can't downgrade 4Bs. But if it comes back negative, I feel confident that it was a negative lesion, right? We've even had BI-RAD 5 lesions, elastography was negative. We biopsy it and it comes back a benign lesion. I feel much more confident that I did not miss the lesion because the elastography told me it was going to be benign. The other thing is now we've had several cases where what looks like one lesion on B mode is 2 lesions. And I showed you one of those cases in the last talk I gave, that one piece was benign fibroadenoma, the other piece was a cancer. And on B modes, you couldn't tell the difference. But on elastography, one side was stiff and one side was soft. So it's really important to biopsy the stiffest area. So a lot of people say, well, why should I do elastography if it's BI-RADS 5? That's why. If you biopsy the stiffest lesion, you get the best radiology pathology correlation, and that's been shown in a paper that was published last year from a large series in China. So with that, I'm going to end, and I hope that I've got you all excited to try to use elastography. There's a learning curve, but I think you'll find that it's very, very helpful, and again, it's putting all the pieces together, and I continue to beat up the vendors to make sure they add more quality factors so that you know that you shouldn't believe that. And we've got a lot of those quality factors in liver imaging now. They need to move that into the breast elastography. So again, thank you for inviting me. And it seems like I'm back in India at least once a year, so I'm sure I'll see you again soon. Thank you.
So, good morning, and thank you for having us here. We have a perspective discussion on DBT versus ultrasound in screening for dense breast. Now, as a supplemental screening method in dense breasts. Now, we all know that breast density is a problem for radiologists. Heterogeneously dense and extremely dense breasts can hide a lot of cancers. Various supplemental methods have been used for adding the cancer yield, increasing the cancer detection rate. But is one of them better than the other? I think that's what's under discussion. And I'm talking on DBT. So to start, I will start with what I always do, show everyone a case. This is a 70-year-old female who's come in for a screening mammogram. How would you guys place the density? Okay, so we are going with heterogeneously dense. Can anyone see a cancer? Oh, I love you guys. You always get the wrong breast. So what do you want to do next? You want to do a DBT? Why not an ultrasound? Sorry? So here we go with the relevant DBT slices. Okay, so after this, we will obviously add an ultrasound. That is part of the discussion. But this is a very small area of architectural distortion, which is pointing us towards a very tiny mass. Now, in order to localize this mass for an effective biopsy, we would need, of course, to do an ultrasound, but a targeted ultrasound is what we would need to do. If I did a rock-around-the-clock screening ultrasound on this, I would not have found this because this was really tiny, and I had to do a very targeted ultrasound to find this. So, in my opinion, DBT should always be the first modality that we add on. And in fact, for all our screening mammograms, whether low density or high density, we are using DBT for supplemental screening. So after this, I would just bring up some figures here that what DBT does is that, first of all, we are using much less physician time because handheld ultrasound, as you know, it's a small probe, it's a large volume of breast tissue. All of us are doing breast ultrasounds daily, and we know how much time it takes to do a good breast ultrasound. So much less physician time is used in a DBT. After acquisition, you're literally taking half a minute to a minute to read it. And if small abnormalities are detected, AD being the commonest, if we direct ultrasound accordingly, and it has an incremental cancer detection rate from 2.2 to 2.5 per 1,000 screenings, which is not bad at all. So over to Yojana.
I think the topic here is supplemental screening for opportunistic screening. So I'm going to talk on sonography. Before I go on to sonography, I just want to go through the statistics, although it has been discussed yesterday quite a lot. See, the burden of cancer breast in India is quite a lot. And what is important is that it is increasing 2% every year. And the mortality as compared to incidence is very high. So mortality incidence ratio in rural population is 66 as compared 4 in urban. See the amount of mortality we have because of breast cancer. And that's because almost 46% of them are diagnosed at stage 3, stage 4. So we need a good supplemental screening which will reach in a rural area or a wider area in India, and which will cut down our mortality rate. A lot of our breast cancer patients are young, and we have highest number of TNBCs. You know, young patients have dense breast. At times, tomo does not see anything in the dense breast, and that's why we need ultrasound. So this is the population-based cancer registries showing the incidence of 5 years. And Madhvi, the highest incidence is in Delhi, followed by Bombay. And the least incidence, you heard Dr. Badwe talking about it, is at Barshi, which is a rural area in Maharashtra near Sangli. So why sonography? Basically, it is affordable. A radiologist can afford it, a patient can afford it. Remember, it is very important our society is price sensitive. Even tomo, people hesitate to go because the cost is very high. It's easily available and accessible. If I go out of my house within 10 minutes, I will get a sonography center. But if I have to do tomo, I have to travel quite a lot. It's sensitive. It is very well accepted. There is no compression, there is no radiation. And there are lots of trained radiologists who can do very good ultrasound. We've been taught to do ultrasound right from our day one in residency. We are not dependent on our sonographers. We are very good at ultrasound. We spend less time because we are very used to it. We can do ultrasound in pregnancy, where we just cannot do tomo. In lactating mothers, in young patients, it gives excellent results, and in post-operative patients. More important is it can cover the peripheral areas of the breast and also axilla. I can pick up lymph nodes, I can diagnose them with the help of cortical thickness, vascularity, that they are metastatic lymph nodes. Tomo cannot. We have tools like color Doppler, Dr. Bar talked about elastography, we have AI. With the help of all these tools, just the press of button, we can do wonders. It's an excellent guide to do all the procedures. It's done for immediately after mammo. So there is no recall that now I want to do tomo, you come back. No. It can detect small cancers irrespective of the density, and hence the survival rate, Madhvi, is high. Lobular carcinomas, lobular carcinomas, non-mass lesions are better characterized and seen on sono. Cancer detection rate is almost at par as DBT. The specificity of ultrasound is very high, which a lot of papers say. I'll show you some. It also reduces the interval cancer rate, and non-dense breast, DBT and ultrasound perform the same. So these are some of the papers which say that in case of stellate lesions, discrete masses and AD, they have equal sensitivity and specificity. This is another paper of AJI which says that no significant difference in picking cancer detection rate on screening ultrasound after DM versus DBT. I'll show you 3 examples to prove this. This is a lady who was 47-year-old, came with the lump which was increasing. The first picture is DM, the second is tomo, so accordingly. So this is a mass which is increasing, and this is what is seen on tomo. Do you learn anything on tomo? Nothing. Now see the ultrasound. Now see the ultrasound. See, tomo is anatomical. Sonography is more, it characterizes the lesion and it can tell you the vascularity. You can come closer to the diagnosis. So this was a solid cystic mass with more, of course I don't have the color picture, but it did show increased vascularity, and this was borderline phylloids. Another case, dense breast, nothing seen absolutely. Tomo done, nothing seen. Whereas on sono, you see a mass with irregular outlines. Third case, a 58-year lady who came with anemia. Since she was anemic, the investigations were done for anemia, hence the bone marrow biopsy was done, which showed metastasis from breast or ovary. And after that, the PET CT was done, which showed multiple marrow lesions and bony mets. No focal lesion on PET CT in breast. What you see is some irregularity on tomo, on DVM and tomo, but nothing great. So these are the pictures, craniocaudal, oblique, and lateral. Tomo didn't add much. Whereas see an ultrasound, a first-year resident will tell you that this is a malignancy, isn't it? Madhvi, you agree with me? So, in short, when you add sonography to mammography, there is a wider reach because it is low cost and low maintenance, whereas tomo is not. I'll tell you example of Mumbai. Way back in 2017, there were 5 tomo machines in Mumbai. Now, in 2024, there are only 7 machines which are added over 7 years. So the reach of tomo is not there. Where will our people go to get tomo done, and how will we get our mortality down? Because tomo is expensive and has got high maintenance. Thank you.
Experts who know the ground realities and who are doing a fantastic job here. And actually speaking, it's been very unfair to them. I have to fight on your behalf, both of you, because it's like a mother choosing between her children, isn't it? You don't choose between mammography and ultrasound. You don't choose between DBT and ultrasound. They've done a stellar job. So first of all, I think a huge round of applause. The pressure's off now, come on. Okay, so what I've said is, I'm going to be a mother, all right? I am a mother. So DBT and ultrasound, and I have included the CEM and the MRI and the PET. I don't discriminate. Okay, the points to consider are the choice of imaging that is available to you, the need for further evaluation, and I think that is a very key point. What's the evidence out there? I'm going to look at a few trials here, a few papers here, and also a couple of trials. Opportunistic screening, this was part of my brief, and therefore I looked at papers that would look at opportunistic screening using DBT and ultrasound, and what my practice is in very few words. What are our choices? You know what the choices are. But the menu is not the meal, right? So choose wisely. What are the test advantages? And both of them spoke about test advantages. The cancer detection rate. Find more cancers, find the extent of the cancer, find smaller cancers, find mammographically occult disease with DBT and with ultrasound really. Options for biopsy in both cases, and confidence in routine recall. So when you tell a patient, you know what, there's nothing going on there, you're more confident, the patient is more confident. Limitations of the test, and that's something that I think they glossed over, isn't it? So let me go into that. The costs, yes, initial and running for both ultrasound and mammography. Ultrasound machines do get upgraded, they do require maintenance, and there are new machines that are coming out with new features all the time, and yes, we want the latest toys. Training for radiologists and technicians, yes, you're absolutely right in terms of being trained in ultrasound from the word go. But with the newer modalities that have come in, a lot of our residents, particularly in the UK, I can say, and I know there are some places in India where they say, oh, you know, our time is divided between doing an MR or reading MRs, reading tomosynthesis, CT, CT-guided biopsies, the works. And with that, their time is divided. So clearly, they do not have the kind of experience that perhaps you had when you started out in terms of number of hours of ultrasound. Time for reading. We cannot deny the fact that DBT takes much lower time for reading. Radiation dose, yes, DBT has a radiation dose involved and ultrasound does not. Patient factors like implants, DBT is not very good for implants. Patient acceptability, there are some patients who may not want their breasts squashed. That's the way it is, and we have to work with it. Risks, like a contrast reaction, for example, with CEM. Pack storage, we need to, in this day and age, think about our carbon footprint. What are the number of images that we are adding on? We are adding on a lot more with DBT and with CEM and MR for that matter. Further factors to consider are density of the breast. Very topical, and it's one of those things that is going to help you or not help you pick up additional cancers. It's an increased risk for cancer as well. Genetic risk factors. So if the chances of finding cancer are a lot more, I would put my foot on the pedal, and yes, I would drive that Mercedes. Okay, so previous radiotherapy, again, it's one of those things that increases the risk of cancer. So I would put more of my money on it and get further investigations done, maybe more investigations at a shorter interval. What's the pathology of the currently diagnosed cancer? If it's a lobular, there's more chance that I might find something else, and that means that the cost involved in the patient's treatment might go up if I miss that one additional cancer. She needs a definitive treatment. So I have to think about the cost, not just in terms of my time or the machinery available or there and acceptable, but also what is the cost in terms of the overall quality of life, etc. Mammographically occult cancer, I have to make a decision whether, how am I going to follow this patient up, because that's a question that does need answering. And also, of course, guiding treatment, most important. So breast density, there's an increased risk of breast cancer, as we know, and there's reduced sensitivity of imaging. I have a few papers here as evidence, and again, like I said, I am not going to discriminate. So there's tomosynthesis. That paper from 2022 showed 13 studies which showed increased CDR in dense breasts in double reading and lower recall rates in non-double reading. So the additional benefit with reduced harm. That's a good one. Supplemental breast screening in women with dense breasts. These were 22 studies. This is a 2023 paper. Higher rates of CDR with MRI, 1.52 compared with other imaging modalities used for supplemental screening. And sorry, DBT and ultrasound both don't win here. Okay, so 1 minute. Comparison of abbreviated MR versus digital breast tomosynthesis. And again, IDC detection rate is higher. Sensitivity for invasive and in situ disease are higher. We're at 95.7% versus 39.1% for DBT. So MR as an additional imaging recommendation. AJR expert panel narrative from 2021, which I'll let you read that. But essentially it says that MR is good, CEM is good. We need to choose sensibly, we need to choose wisely. Diagnostic performance of automated breast ultrasound versus handheld ultrasound. And this is one study from 2020 which said that there's strong correlation, which is, again, good. So you're not missing out when you think you don't have ABUS. I'm sure there will be more studies on ABUS that will be published soon. And then another one on CEM and versus conventional imaging. So abnormal findings found on CEM. CEM has much better diagnostic performance than digital mammography and ultrasound alone in dense breasts. So there you go, again, another choice. The BRAID trial, I told you I'll speak about a trial. So this is one of those that is ongoing and will be completed in 2026. It's looking at 3 things that are being added to routine mammograms. One is ABUS, the second is CEM, and the third is abbreviated MR. And this is the second cycle that the women are going through. So it's a 6-year study, and we will know soon whether one or the other is superior and what needs to be added on in dense breasts. So those with BI-RADS C and D category breasts were selected for this. I was asked to speak about opportunistic screening, and to my limited understanding, this is what I thought in my head. So I put it down, I'll hold my hand up, this is what I thought. Limited resource setting, it'll be quite useful. Low and middle income countries, where there are no organized screening programs, it will result in earlier cancer detection. You know what, I was proved wrong, because there are studies from all over the world, including countries that have established screening programs and those that don't. So we have a study from France there, a couple of studies from Switzerland, then there's that one from Malaysia, and another one from Brazil. So all sorts of incomes, in all sorts of income countries, and everywhere shows that opportunistic screening yields good cancer detection. Now, mind you, this is with standard of care, as in digital mammography. It's not talking about, I'm hoping it's digital mammography in most places, but really it's not talking about DBT or ultrasound. So there really aren't any studies comparing one of those to look at supplemental screening. So perhaps, therein lies an opening where, maybe a randomized control trial can be instituted for that, for DBT and whole breast ultrasound in the Indian subcontinent. As far as practice in the UK is concerned, we have a screening program, you are aware of that, and we don't actually recommend even mammograms in the breast clinic unless the patient has a focal area. So really, the latest from the British Society of Breast Radiology is that we would not recommend even a mammogram. Yes, it was being offered as a screening tool, but really, we don't need to offer that. If the surgeon says, I'm not feeling anything, we would rather they not have anything. Everything has its own false positives. This is my practice. I think I spoke about this yesterday, and I think it's more or less what Madhavi does as well. With DBT and, if required, focused ultrasound, MRI with the right indications, and a biopsy as needed. Most important, I think, patient information and education. Does the patient know why I'm doing a test? If I'm doing a DBT, do they know that I'm doing it so that I can find something and not just so that I can rule it out? Are they aware that if I find something, I will do further things? I will do maybe an MRI. I might say I'm going to need to do a biopsy. I haven't seen anything on DBT, on ultrasound. I'm going to need to do an MRI guided biopsy. Do they know what they're going into? I think that is the important thing here. And yesterday, Badwe sir spoke about the patient being at the center of everything. Yes, absolutely. The patient is part of our team. Are we aware, and are we getting them into that circle? Are they with us? So beyond the brief, I can never keep to the brief. The patient as a whole, that's the most important thing. Managing patient expectations and understanding, I think that is key to whatever it is that we do. I think the question that needs to be asked is, why? Not why not? Just because I can do a test, just because I have the latest MRI scanner, I'm not going to do the test. Why am I doing the test? I have to have a relevant answer for that. I'm sure you're all doing it that way, but I think to the more junior members of the team, those who are just embarking on their career, this is the question that you need to ask. Just because it's not good enough, it's a very teenage term, and we are out of that. What's the value of clinical examination, breast self-examination? I think breast self-examination is of value, and I do tell all my clients, not patients, people who don't have breast cancer, I do ask them to examine themselves, just so that it does not increase their own anxiety. Going to somebody else who feels their breast once in every 3 years and says, oh, maybe that's lumpy, and she says, but you know what, that was always lumpy. So I say, well, you are the best judge. You know your breast, your body, like you know your study table, your dressing table, your kitchen, right? Anybody moves that book half an inch, God, I'm going to be cross. So, you know your body better than anyone else, so use that. Thank you, that's me done.